All right. All right. Now we're going.
Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ricky Ditzel, Evan Baines, and Brock. How are you guys doing today?
Good. Glad to be here.
Awesome. So I know Ricky and Evan, you guys have done podcasts with us, but just in case somebody is listening for the first time, could you guys do a quick introduction?
Tag
Sure, man.
it, Ricky.
Hey, I'm Ricky Ditzel. I recently came off active duty in April after being in the Army, and I am the Director of Research and Education over at the Special Operations Medic Coalition.
And I'm Evan Baines. I'm the 2nd Battalion, 3rd Special Forces Group surgeon, an ER doctor, former 18 Delta back when I was a real soldier.
My name is Brock. I'm a current SOCA medic and also a civilian critical care paramedic.
Outstanding. And so today we're talking about the transition of military medics into the civilian workforce. You know, it's a very hot topic on social media. You know, recently they've had some legislation passed about that, and so what I got is a mix of providers with both experience in the military side and civilian side, and we can try and hash this out. So my first question is, does the training that military medics, and when I say military medics, I'm meaning SOCMs, does that training and experience, will that translate well into civilian medicine?
So I think from my perspective, it translates very well in the sense that I think the training that our medics get is excellent and gives them a good grounding in medical principles. Our medics tend to be very strong in procedures. What it doesn't do is it doesn't give them the breadth of patient exposures that you see in the civilian world. You're not taking care of 70-year-old folks with CHF, COPD, and coronary artery disease. You're not usually taking care of a lot of pediatric patients. Obviously, some of this is depending on what kind of deployments you catch. So it tends to be a very focused kind of experience. So a lot of expertise and a lot of great skills, but it's deep and narrow, and it doesn't cover everything that a lot of civilian providers need.
Yeah, I think that the programs like Dr. Baines just said is we get a really great narrow critical competence in a very specific environment-based medicine, backed by extremely good procedural skills, and then in certain topics, really great clinical skills as well. Where those don't translate too well to is in hospital-based systems. So systems-based problem sets, hospital equipment, some of the specific patient populations. But what it does provide is a foundational layer, regardless of what the foundation is, and some form of background knowledge for medics. And it also comes usually with a lot more passion and compassion for patient specifics, because your patient population, for however many years you were a medic, were typically your closest friends and family. So you really build this compassionate provider model that you can translate well into a civilian-based system.
I'm going to agree with both Ricky and Doc. I'll speak from personal experience. Coming out of the schoolhouse, I felt very prepared in trauma medicine, and not. I didn't feel very comfortable, although I did have the basics for clinical medicine. So that was something that personally I was lacking, and coming straight out of the schoolhouse going into 911, that was something I really focused on, was that clinical aspect. And those 911 providers, I wouldn't say aren't versed on trauma, but they just don't have our perspective on trauma, and that was something that definitely I passed on to them. So it was a mutual relationship.
Right. I think, the key is kind of the context of the training, right? In military medicine, it's all about combat, it's all about trauma, and generally we have a pretty healthy population that we're dealing with. So we're trained in, horrific injuries for an extended period of time, but generally you're dealing with pretty healthy people versus maybe a civilian medicine. You kind of have like the spectrum of things. You can have trauma, you can have cardiac issues, you could have respiratory issues, you have diabetic issues. There's just a multitude of things. At least pre-hospitally, you're dealing with it for a relatively short period of time generally, right? So I don't think that it's that military medicine doesn't really prepare you for civilian medicine. It's just they're training you out of context for practice in a civilian setting. I don't know. Do you guys agree with that?
Yeah,
Yeah.
I mean, sorry, Evan.
No,
Um,
go ahead, Rick.
so you got to look at where the medic model is contingency based medicine, right? So your job is to think and frame your mindset to be in the op order when it comes to contingencies. So what am I going to do in the worst case scenario? And then and that's the initial context, and then obviously you add on layers to that, especially with the audience that listens to this podcast mainly is then there's more clinical. Then you're the guy that take or the girl that takes care of your whole team and their clinical needs and their psychological needs and not just their trauma needs. So that aspect alone, usually medics are definitely more holistic than allopathic because of that. They tend to look at the whole patient because of that family based model, but um, you're definitely more contingency based minded than in the hospital, where you might not have the worst case scenario roll into the ER sometimes, like Evan deals with. We don't really think about social work and housing situation and living condition and things like that.
All right. So because in the civilian world, and I mean even in the military world, there's multiple levels of provider. Okay, so we're talking, your basic EMT, let's say all the way up to, an MD, an ICU doc. Sky's the limit, right? Um, to what level do you think that our training applies to? Because it's kind of scattered throughout.
Yeah, I mean, there are aspects. I mean, my 18 deltas are being trained on doing fasciotomies, which is a procedure that I couldn't get credentialed for even if I wanted to within my scope of practice as an ER physician. So if we want to judge it by what is the most demanding procedures that we train folks on, it's a surgeon, it's an MD level. If we wanted to talk about the civilian clinical reasoning, then it's a much lower level because most guys just don't really get a lot for that kind of civilian clinical medicine. So I think that the problem that we've faced, and the problem, I mean, look, I've been in this business since the early 2000s, and I know you guys all have a lot of experience with this and have seen it too. That's why we go back and forth on things like certifications and which ones apply, because there's not really any one good fit.
I really think it's program dependent. I know some programs are um, not as progressive as others. If you show that you show up, you show the providers that you know what you're doing, and that you give them a little bit of a background, they may be more opportune to let you do a chest tube in the ER or do that intubation. Whereas some other programs, they don't want you per se doing that, whereas that's going to be like the PA or the MD doing it. But like I said, it's really on the program to give you your scope of practice.
Right. How well did you think, so being a SOCM and transitioning to critical care flight paramedic, um, do you think that was a pretty smooth transition?
Yes and no. Like like we keep saying, the trauma knowledge was there, very well versed in that. Um, but the down and dirty critical care medicine, like different types of drips. SOCMs, you're not taught about levo. You're not taught about cardizem. You're not taught about dobutamine. All that was learned through continuing education and hands-on experience. So personally, I was very lucky to have people that were very hands-on with me and respected, my background and really wanted to show me the ins and outs of critical care on the civilian side.
Outstanding. Now, Ricky, because of this COVID thing up in New York, you were actually working as a PA, as I believe. Is that correct?
Yeah, we utilized the executive order with New York Presbyterian, and we had three prior SOCM medics from three different units working as physician's assistants on a tracheostomy care team.
Okay. So going from a SOCM to a PA, how well was that transition?
We worked for an attending otolaryngology surgeon, and then we worked for a pediatric otolaryngology PA. And I can tell you that where it does well is that SOCMs are autonomous providers, or supervised autonomous providers is kind of the word I use, or the phrase I use now, because even when you go overseas, we like to argue that we're fully autonomous, but there's still a scope of practice. There's still a governing body, and there's still a doctor or PA that you answer to at the end of the day based off the decisions you make. So it's supervised autonomy, and that model was perfect for something like a tracheostomy care team, because why? Tracheostomy care is very procedural based for what we were doing. So we were doing basic trach care, which is suctioning, cleaning, rounding, changing out intercannulas, educating nursing staff, educating families. But then we're doing more advanced procedures like planning their speech and language therapy, planning their decannulation trials, decannulating the patients, choosing whether or not to discharge the patient based off their course of care, integrating with the vet management teams, etc. So we functioned as PAs, and I think it worked well in that setting specifically because we had a very good left and right limit, right? I wasn't in charge of the entire patient's care. I was able to narrow focus on one thing, and well, more than one thing, but we just, one thing only, which is tracheostomy. So that means swallowing, that means the upper airway, that's the lower airway. And then all of our patients were COVID positive. So now we're making also decisions, recommendations based off their clinical signs and symptoms with COVID, but I wasn't functioning as the internal med PA, right? I wasn't adjusting their medications. I wasn't adjusting their drips. I was, changing vent settings and making decisions about tracheomalacia and other processes like that I wasn't familiar with as a active duty guy, kind of like Brock was talking about. But we have, and I say we as the SOCM community, has a really great adaptable and resilient background. So it took, I'd say, 4 or 5 days for each of us to really understand the basics of what we were doing as far as the trach care. But when it came to the clinical course and decision making and integrating with the other attendings and letting them know why we shouldn't discharge a patient or why it's safe to send that patient to a certain rehab facility, that took about 2 to 3 weeks of working, 12 to 16-hour shifts. So that didn't require a bridge course, but once again, we are supervised autonomous providers for a narrow focused, important but still narrow focused skill set.
Right.
And
So,
one thing that I'm hearing from both Ricky and Brock, and something that I've experienced as well, is it's a combination of humility and confidence that you need to bring to this in order to transition well. Because I went through medical school and residency with a bunch of guys who had a similar background, and I've seen people come from various fields and coming at it with a certain amount of humility for what we don't know, like confidence in the skills and grounding and process that we were trained in originally, but having a lot of respect for what we don't know. I still try to bring that in my role, and I think it sounds like what you were talking about with that your trach team, Ricky and Brock, when you were transitioning into a critical care flight paramedic. That really pays dividends as part of the transition, is to let your competence speak for itself, but coming in with a little bit of quiet professional.
yeah, absolutely. I think, just having some humility is going to take anybody, far. I think regardless of how what level of training you have. Anybody can outrun their headlights. So, if you don't have any humility and aren't willing to, listen to somebody else, or even, listen to a piece of advice from another person, I think you're really asking for trouble.
Right. And I think something Brock said that was really important, and I'll kind of jump on, is it's not just humility, it's understanding that you don't understand their daily life of work, and they have no true understanding of your daily life of work. Go to any conference for SOCM and try and explain to another unit that's in the DoD what your unit does, and people can't understand it, right? Like if you go to the 82nd and 3rd ID and try and tell them what a flight paramedic does, they still have an image of their head of what that looks like. So translate that model to a workforce that maybe not have any military background, and then you use all these pro words and fancy stories of what you did in the military is medically, and it's whatever image they create in their head. Just like I'm sure Brock and many guys like myself and other guys, we have an image in our head of what critical care paramedicine in an ambulance looks like. But until I'm sure Brock got into that back of that truck and took a critical care transport and started looking at his protocols, did he actually know what that meant for his specific department compared to other locations too? So you have to it's not just that humility too. It's understand that they're not going to truly fully get it because they didn't live that at all. And that's kind of tough for a lot of people to understand. And that's one of the challenges and barriers we have into bridging SOCMs into the civilian department, especially in healthcare.
So if you guys had to pick a level, a civilian provider, whether that's, EMT basic, all the way to the top, where, if you had to say in this field, and I'm not talking about your stellar performers, I'm also not talking about your knuckle draggers, what field do you think most closely translate?
Well, I'll speak up and try. I'll swing for it. My true answer, and it's the answer everybody doesn't want to hear, is I don't think any of them. As far as lateral transfer, I think the military medic with the SOCM, whatever level you are, is its own job with its own set of boundaries, and it can fit in the hospital system as its own thing. Like I said, a supervised autonomous position really can be its own thing in a healthcare-based system, like a trach team, because or a wound care team, for example. But if I had to pick one, and I couldn't do a hybrid of a couple because I would
Right.
blend them all. I'd blend them. I'd go somewhere in the advanced nursing with a specialty. So like a wound care nurse. So somebody who has a years under their belt of taking care of patients and making recommendations to physicians, but not fully owning a patient by themselves, but they have an advanced skill set that they can go into other floors and walk in the room and say, here's my plan. I'm here to do your patient's decubitus ulcer prior to gen surge showing up, blah, 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 blah. So that's in a hospital-based system. And that's kind of my answer.
Okay.
Yeah, I mean, I think I agree with that there's not one good fit. I mean, the most obvious would be something like a paramedic level because it's, closest to what we have, and many of the guys are getting those certifications already. But even there, one of my biggest concerns medically that I see with the guys in my battalion and really across the force is that sustainment training is a challenge. I mean, for the Deltas, it's always shooter first. And I know that in other units, it's, maybe a little bit better, but not much, where medics are being pulled a million different ways. And frequently medics are pulled away from whatever training they have. So even the guys who come out of the schoolhouse, if they come out of the schoolhouse with a paramedic certification, which they've done in the past, I'm not completely up on whether they're doing it right now, they are not using so many of those skills and really not even revisiting them much more than once every 4 years. So in some ways, I think it might be easier for somebody to transition straight out of the schoolhouse than for many of the guys who are not doing deployments and missions where they're actually applying their skills, which right now seems to be the majority, it's going to be even more challenging. Now, that excludes, the guys who are actually catching missions or really, really interested and take it upon themselves to be up to date. But I worry about the guys who come out of the schoolhouse and then basically are just like, yep, I'm, the junior 18 Bravo, and are not doing that. And then if they say they want to transition to medicine, well, I don't know what they transition into.
Personally, I think the paramedic level would be a good starting point. That said, I think there should be absolutely continued education right up front, and some sort of bridge course to get them in that civilian medicine mindset, but also not not forgetting their background as a SOCM, and maybe like a mutual um, type of a program where we could teach, or give a little bit of a background of where we came from, the type of medicine we practice, the type of patients we saw, and then also inside of that continued education, get that education that's vital for civilian medicine. That 911 paramedic on the street showing up to somebody's house at 2300 at night, and they're having a COPD exacerbation. You just really don't see that in the military medical realm. So essentially, my answer would be a paramedic with some additional training to get you spun up on civilian medicine.
Okay, cool. So, let's say we're aiming for, a paramedic, advanced paramedic to physician, somewhere in there, right? And obviously people's, hopes and desires are going to change, but generally I've only heard people talk about those areas, right? Should medics be allowed to just walk into a civilian job? Okay. Should they be required to attend a specific bridge course, or should they just get in freaking line like everyone else?
So, as the director of research and education at SOMC, I fight for guys to not have to just stand in line like everybody else. So I don't think that you should just have to stand in line like everybody else. But there's multiple ways to approach that, right? So like Brock said, if you're going from paramedic to paramedic, it doesn't matter if you're a 15-year paramedic in Florida and you're going to move to New York City, you're going to have to do training or a probation, just like moving police agencies, right? Or police departments. There's going to be some type of train up. So I think it has to go skill based. So if you're going from EMT to paramedic, sure, you should be able to sign on and get a job because you're an EMT or you're a paramedic, or you might have additional certifications. But like we know, the CCPC and FPC, TPC certs are international. They're not state credentials. Now, something like nursing or PA or MD, DO, I think where you can make the best money is either by giving better credit at the admissions level for the JST and showing a higher degree of academics. So, showing that the coursework is difficult. And the other thing you could do is have portals for the applications or have representatives on the admissions department. So for MD, it shouldn't just be, were you a veteran on your application for certain schools? It should be more than that. And there should be a better understanding of what these guys and girls bring to the table. And then more importantly for PA was built because of Navy IDCs. So for the civilian PA side of the house to not be actively recruiting veterans or special operations veterans for that matter is really backwards. So I don't agree with standing in line like everybody else. However, everybody's got to take the MCAT unless the program doesn't require it. Everybody's got to do the PAC boards and meet those prereqs, but we can do some advocation.
Hey, Ricky, since you're kind of a giant nerd and you might know this, has anybody looked at outcomes across the board for different levels of training, whether it's MD, RN, PA, as far as how people have done from our community? Is there any, it would be hard to do that study because it's like, what's the definition of success other than test scores? But I'd be really interested to see how people from our communities have done once they have matriculated? I know that there are a good number at all the different disciplines at this point.
Yeah, so there's three of us trying to work on that right now, from the AMCAS side of the house, and we're trying to pool that data, but we don't have an actual published study on that. So there's like I said, we got three guys that are going to look at it, and I'm sure we can bring more people on because I do think that's a great way to approach it. Um, but what we did look into at SOMC was that the Pat Tillman Foundation has about a 33% special operations medic representation of all Tillman scholars, which is pretty impressive, especially considering that most Tillman scholars are in master's or above level programs when they're accepted into that scholarship foundation. So I think we need that data. More than willing to work on it, and I hope more people jump on it. It'd be a great thing you could do. Hopefully there's a PhD student out there that's looking for something because we can run your thesis on that all day.
Yeah, I'd be really interested. I mean, maybe we can talk offline about this, but I think it'd be interesting to see what would happen if we just like got a hold of USU and said what have been the outcomes over the past 10, 20 years of, SOCA medics. And that would be a pretty easy data set to come across, I would imagine.
Yeah. What do you think, Brock?
I'm just gonna back up what I said on the last question. I don't, and I agree. I have to agree with Ricky on this. I don't think anybody should be able to, um, you know, come on with a program and be essentially good to go to practice medicine. There has to be continued education. There has to be some sort of skill sustainment. There has to be some sort of probationary period, which is all vital. And I actually am a big fan of like on top of all that stuff, um, classes on different diseases and medications and stuff like that because just knowing what you're going to be up against and what kind of medications you're going to have to use for those disease processes is really important. And definitely going to agree with Ricky. I really don't think we should wait in line per se. Um, I know that some states put preferential hiring for veterans and military folk. I can't speak on all the states, but I know that some of the states do have that, and we get preferential hiring in front of other people.
Yeah. I gotta be honest. I don't really know where exactly I stand on it. I agree with bridge courses. There's some skills that our guys have. They have them down very well. But then some areas they need to be cleaned up. But at the same time, I can't help but think, what about the other side? Okay, say there was a paramedic or a nurse or a PA or a doc. Let's say Captain Baines, X number of years ago says, I want to be a special forces medic. I'm already a doctor. I'm ready to go. I would tell you to go pound sand. You're not ready because you haven't been through the training. You know what I mean? A bridge course on how to ruck and how to carry a person isn't going to be enough. You know what I mean?
No, I agree completely.
So I think, and when I came out of service or active duty into the National Guard and I started looking for jobs, I definitely got lots of pushback about, you haven't really put your time in. You didn't really earn it. So I could see where somebody's, graduating from a bridge program might not even be allowed to, come play just because they didn't earn it. You know what I mean? So I don't know if that's kind of the hot new thing is just have a super truncated bridge course. I'm going to tell you everything you need to know to pass the test, and then we're going to spit you out into the workforce. I don't know if we're really helping guys succeed by doing that either.
Well, what I was trying to get at with that study question, I think there are two pieces to this. There's what is our responsibility to our veterans? So what responsibility do we have to help veterans who have served their country honorably transition into other careers and be successful. And then the second piece of this that is equally important when we start considering things like bridge courses is, what do these veterans bring to the table that is unique, that makes them strong contributors and valuable enough that may offset other limitations that they have. So, what I've historically seen are, prior special operations types in medicine tend to do very well in leadership. They tend to do very well running a team, working with a team, being a team member. And they tend to bring unique insights, a certain degree of autonomy and comfort with ambiguous situations. And those are all real assets that I think make a prior special operations medic desirable in any of the fields that we talked about, so long as we can ensure their other training is up to par and that they're brought in. So, some of this question is, well, what preference should veterans get? What do we owe a veteran? But then, in many ways, if we're trying to push the sort of these kind of transition courses and pipelines, the other thing that is worth asking is, well, what is society, what are these various professions getting in return when they hire a special operations medic?
Yeah,
Absolutely.
you need multiple things there though. It you can't just qualify everything too. That's where we're failing on our side of the house. We have to quantify, and I think that's why you brought that study up. Is like, we got to be able to quantify what we've given back. Further is I kind of just blanked out what I was going to say. Oh, we always talk about putting guys and girls in the healthcare from just a paramedic to physician job, but we really could bring the healthcare system some amazing administrators. And it's something we really don't advocate to our senior guys and girls, or even some of the younger guys and girls, as they're trying to transition out, is all those qualities you just listed, Evan, are great qualities for a director of a department inside of a hospital, or a senior manager, or a CEO one day, right? You have leadership, team building. You've ran a budget overseas because you were a special operations medic. You've done gap analysis, right? Because you've said, how much equipment can I purchase with how much money they're offering or allowing me to have overseas, and I have a rolling stock and I'm looking at expiration dates. Those are all things that are translatable skills, especially in a hospital administrative job. And we really don't ever have that conversation either, and we really don't promote it either. And that's a well-paying career and job. Um, so I think we need to quantify some other things too, and not constantly just qualify our guys and girls for what they're doing.
Yeah, I think we just also owe it to our guys to just educate what is possible outside. Nobody ever talks about the respiratory therapist. Nobody talks about the administrators. I can imagine why. But, there's so many other positions. Nobody ever even brings up that it exists. You know what I mean? So I think we have to, especially if you're looking to transition, you really got to educate yourself on what are all the different possibilities and what do these people do.
I really wish. It's funny. My wife, at one point, she does tech stuff, and she worked for companies that contracted with the military, and particularly with the Navy side. And they were involved in actually a system where it was a website designed for people getting out to try to get an idea of what they could transition into and what opportunities existed to gain credentialing that would assist them in a career. And there are so many of these programs out there that, I still routinely run into enlisted medics who are not aware of the Enlisted to MD program up at USU. I've got to put that plug in there. I'll probably mention it one or two more times in the podcast. There are all sorts of other programs out there to try to get you into these various fields and help you navigate the process. And guys just aren't aware of them. And I do wish, targeted towards our special operations medics, there was a central repository of different career path options, and just kind of educating guys on what that pathway looks like and what programs are out there specifically tailored to them to help get them there in a timely fashion.
Sign up for SOMC to find out more. That's why we exist, to help you
That's-
transition. Thank you for your sales pitch, Evan.
Yeah, I thought that was a good setup.
So, we've been talking about, possibility jobs outside the military. Um, should we be required to do a bridge course? Should we just walk on? Um, how much responsibility does the DoD have for setting guys up for success when they go to a civilian job? Because I mean, their primary focus is war fighting, and having a qualified, competent medic is a freaking hard job to do. On top of that, let alone on top of that, trying to prepare him for him leaving, which they do not want whatsoever. So, how much responsibility does the DoD have in all this?
It's a difficult balance of, the more you facilitate a guy transitioning into a civilian career, the more likely it is that they're going to get out, and it potentially will sap your force in many cases of some of your best people. But at the same time, I do think we have a moral responsibility to prepare soldiers. That most soldiers are not going to go career, and what even the ones that do not go career, they've served their country honorably and absolutely deserve some help navigating into a good career. Not to mention the fact that a bunch of unemployed veterans on the streets does nobody any good. So I think there are lots of reasons why we need to facilitate that civilian transition, but it needs to be some kind of balancing act.
So I have a very different opinion than I think most people do on this question, which is I think the DoD already does a really incredible job. And I think it's like most programs within active service is the services are underutilized, right? Think about, and not everybody had this, but for the current generation of new guys and girls, even back 8 to 9 years ago, when you're in advanced individual training, if you're Army, and they bring a finance officer who's a civilian, who's probably CFO or something, not CFO, sorry, CPA, and is like, here's how to invest money for the 19-year-old or the 18-year-old. And this is all you need to do. And by 33, 40 years old, you'll have $1 million if you just do this. Fast forward 6 years, how many E5s, E4s, and privates do you know that are broke, right? But they had the program available to them from day one. They just don't use it or pay attention to it. And then you now have the Soldier for Life program, where you get briefings from Department of Labor and financiers, or more finance people in this department and education departments, people who do your resume writing for you, and Pathfinder programs. All these programs exist, but they're not utilized. So it's really hard for me to say that the DoD is not doing a good job helping people transition out of the military. It's really hard for me to say that the DoD is not setting people up for success, because they did. Whether you did 4 years or 20 years, you had a career, so you have life experience that undergraduate students at a college would pay money for because they can't get a job because they have no experience. And there's all the educational benefits, and there's all the online programs that you can get involved with. And for a lot of it, they give you a lot of hard skills and they give you a lot of soft skills that you can apply to with a job. So I don't really know. I think, like Dr. Bain said again, is there is a fine balance of responsibility, but it's using the resources that are available to you to your advantage, and actually preparing to get out of the military.
What do you think, Brock?
I'm going to agree with Ricky on this. I think the DoD has a lot of great programs, and they're out there, and I feel like it'd be more on the individual to um, utilize those programs, and keep up with their skills and their skill set of whatever MOS they have, and keep track of any college credits they might get during active duty, and prepare themselves for whatever career path they want to go to outside of the military, whether that, stay in medicine or do something else. It's just knowing that the DoD has a bunch of different programs to utilize, and making sure that you utilize those programs to the best of your ability to make sure that your transition is as seamless as possible.
Yeah, I mean, Evan, do you think that it's the DoD's fault that nobody knows about EMDP2, or is it's a tactical level problem? This is not a strategic level problem. Guys and girls aren't failing to get out of the military or being set up to be successful on the other side because of a strategic issue. I think the issue lies at the tactical level at your everyday office. Is if I'm a platoon sergeant and I'm not telling my new people, regardless of what rank they are, that there's an EMDP2 program available, I'm wrong. Or if I'm not telling them that they can sign up for things like the Committee on Surgical Combat Casualty Care or COTC. You don't have to be an Andrew Fisher to be on COTC or Frank Butler. You can sign up as an E5 and try as long as you bring something to the table, right? But we fail a lot to put those things out there. So from a strategic level, what does the DoD do? People complain and say there's a gap, like there's no way for me to transition to becoming a doctor. So they go, hey, here's EMDP2, boom. They don't give you all the layers of how to make that happen, but they give you the program. Now it's at the tactical level to teach guys about college. Well, there's an ed center for that, and to teach guys to put the application in at a certain time, how to do a resume, and all these things, right? So I think it's more of a failure at the tactical level than a strategic.
No, I mean, I agree with that. I just think that it would be nice if some of these programs would be somewhat more centralized so that guys could figure out, oh, okay, here's the IPAP, here's enlisted MD, here, kind of be able to see it all in one place and not have it be so dependent on who they wind up as their platoon sergeant. Make it a little bit easier for guys. I mean, they're still going to have to do all the legwork themselves, but something where it was a little bit easier just to find what was out there would be nice.
Yeah, more to you. I agree. Everything's on 18,000 different websites.
Right. And on top of that, you also need to find the time to actually do it. And I mean, let's face it, generally we procrastinate when it comes time to transition out. Usually we wait, and sometimes it can be a kind of a spur of the moment idea, like, oh yeah, I'm not going to re-enlist anymore, and I'm going to go be a PA, or I'm going to go be an MD, when like you have put no thought or effort into this plan, right? So guys need to, just be honest with themselves, like, what do you want to do? And start just knocking away at getting the information and what is required. And there is always a way. I mean, just like in the service, there is always a way. There is always a way into whatever job field you want to go into. It's just a matter of gathering their information and just putting the work in. I mean, I think that veterans should get some preferential treatment in that it's the barriers are reduced in some ways, but I mean, they are more than capable and have the experience as long as they're shown, okay, this is how you do it.
I think one little tangent that I think would be interesting that goes along with this is the idea of what is the value to the DoD of getting soldiers various certifications. So whether it's National Registry paramedic, whether it's flight medic, and I'd be interested to hear you guys' thoughts. I will tell you that I think my biggest concern with our medical system right now is that our medics aren't getting enough reps with real humans and real patients and real sick patients. And one way to facilitate that is through civilian certifications. It just makes it a little easier coming through the door for the civilians who don't really know and haven't been fully acclimated what our guys can do. It at least gives a baseline. So I see some real value in that, especially if we can try to leverage and increase our military-civilian partnerships for medical training. But so I think there's some value in the DoD trying to give these guys these. It's not just as a career thing, so that when guys get out, but I think there's real value to the DoD in making sure guys get some of these certifications because it enables them to continue their medical training while they're still on active duty.
Yeah, absolutely. I mean, here's a perfect example of it. The National Guard. Okay, so in our unit, You have your Delta. He could be a fireman, he could be a paramedic, or he could be a surgeon. Okay, you just have that kind of breadth of knowledge and experience. Okay, so when guys ask me what's the difference between active duty and the National Guard, that's usually what I bring out. In the National Guard, maybe they're not with each other every day like you are active duty, but the breadth of knowledge that guys can bring to bear into a very small team is, very broad, and it can be very deep. Um, and you use it to, great success. Like if your senior medic is an experienced ER doc, you're sitting pretty good compared to, your partner team, your partner active duty team, where they're 18 deltas, both experienced, but have nowhere near the depth of knowledge that this other team can bring to bear. So as a strategic or even a tactical situation, this person has enough knowledge and experience from both the tactical side and a medical side. That team is able to, do more and be in a riskier spots or have more responsibility just because they have this depth of knowledge.
Yeah, I
Yeah,
think
that's
it's going to be really interesting.
complete true.
Oh,
You're good.
I agree completely. And what I think is going to be interesting to see is DHA kind of trying to streamline things and in many cases downsize some of the military treatment facilities to focus in on just caring for soldiers and getting the families and the retirees back out into the civilian system. It limits the training platform that we have in our MTFs. It's going to cut down on the number of actual sick patients that we have in the military treatment facilities, which in turn I think is going to necessitate an increased interaction between our active duty medical personnel of all stripes, not just the special operations medics, with civilian institutions in order to get that experience. So I just think it's going to be interesting to see where military medicine goes in the next 10 years to address this problem of how do we get continuing medical experience.
Right. And I think,
Yeah.
COVID-19 is a great example of when people, like, we needed more providers. We have all these medics, and then everybody recognizes, well, they haven't actually been doing medicine for, months, if not years. Well, how do we get them spun up so that they can go ahead and tackle, COVID-19? If we put this type of effort beforehand, instead of being reactionary, we're, being proactive, we won't have to jump through our butts anymore, or at least less, when crises happen.
Oh, most definitely. And I mean, I lived that experience. I was spoiled and fortunate enough to get out of the army right when we stood up a hospital, and it was staffed with 80% special operations veterans, more than any other population, and then we had some guardsmen as well. Um, but going back, I agree with Evan. If from a strategic standpoint, if we could get a moonlighting agreement or a civ mil partnership for continuing education, then yes, the trade-off from the administrative side from the hospital would probably be requirements for credentials, right? To make a smoother process or to have a better understanding of what guys bring to the table. But to your point, Dennis, putting the effort in early, having a global understanding of what this brings, if we're really going to talk about a whole community approach in crisis response, then the whole community includes, especially your military, your national military, right? And I think we're really trying hard to use the model that we had in the field hospital. We're really trying to use the model we had inside of the New York Presbyterian Hospital to show where we could put special operations medics. And we have a lot of hospital administrators and providers that were there that agree with supervised autonomy. They do think there should be a direct transition to the healthcare workforce. They do think that it would require a small amount of education. um, but they don't agree like we do that you just become a nurse or you just become a PA, that it would have its own niche role. And that's exactly what we are, right? There's no, the 18 Delta is an 18 Delta. Nobody else is an 18 Delta. Even for the job I did, right? I'll still never be an 18 Delta. And I don't have that skill set. So that's kind of my tangent real quick.
Now, couldn't we just make the MPT program or medical proficiency training program just a little more robust?
I mean, robust as far as
Number of sites, the
yeah,
amount of
number of
time
sites
allotted
and
to it.
frequency. Yeah,
Yeah.
number of sites, frequency, and time allotted. I would be beautiful, right? Because uh like we all said, like take the special operations part away, put me back in the 82nd when I come out of AIT and I'm like, man, I'm ready to go treat a quad amputee because I saw it on Rescue Randy. And guys and girls do it, right? They've done it for years. However, we also, those same guys and girls had a hard time adjusting to whole blood, right? Because they didn't see real patients for a really long time. So I do think MPT, especially for the soft community, increased frequency, increased understanding from the hospital side about what we can give that, what we can do inside the hospital, because it doesn't matter if I go to MPT site more frequent, but they still limit my scope, it's still a big waste of time.
Right. Hey, Brock, what do you think?
I like the more robust MPT. You got to think of where all these groups are. There's probably some sort of level 1, level 2 trauma center that is nearby. Getting an agreement with the unit and the hospital to get those providers inside the hospital, getting real patient exposure, getting in the ICU, getting in the OR. Keeping up those skills, especially those 18 deltas that are I can't even think right now. Sorry, guys. Edit this out, Dennis. Um, that are trained in those skills and be able to keep those skills up is super vital. MPT right now for the SOCM and the 18 Delta is every 1 month every 4 years. It why can't we do 1 month every 2 years? And just maybe add that on the end of SOCM refresher or something like that. What Doc said, he's the skills, keeping up with your skills is a huge problem, and it generally falls on the hands of the individual to keep up on those because of admin tasks, op tempo, and things like that always usually get in the way. So I'm gonna have to. I would like a more robust MPT program. Absolutely.
Let me actually chime in on that because I trained in a level 1 trauma center in emergency medicine. I'm credentialed right now. I work at a level 1 at ECU. I haven't worked there in a little bit because of COVID. But I also work at some little rural shops. And I also think another area that the MPT system could be improved is everybody has this idea that you need to go to level 1 trauma center. And we hear that, oh, it's got trauma in the name. And oh, that's level 1. That's got to be the best you can get. The problem with our guys training in level 1 trauma centers is that you've got almost inevitably you have 8 million other learners there. Yep. And you're also working in an environment that is the exact opposite in terms of resources from the environment where most of our medics are actually going to apply their trade in the military. And I think there's actually a tremendous amount more value in many ways to work in a little rural community ER or community ambulance system where you don't have the support, you don't have the resources. I see crazy stuff in this community ER that I work at on the regular. And part of that is just I have a horrible black cloud. But it's the thought process is a lot closer to the thought process that you're going to have to think downrange of how can I get this guy stable enough to get them transported to some place where somebody can actually deal with this horrible problem that they have. So I think some creativity with the MPT system, actually, of moving away from trying to get everybody into the big, trauma center hospitals. But I also think in those little community shops, many of them are much more short-handed for personnel. So long as you develop a meaningful relationship with the people there, you'll get just as much, if not more, opportunity to do the procedures that you want to do and be hands-on with the patients. But it's also going to give you a very different mindset that's probably a little closer to what you're going to need as a special operations medic.
Evan, what about the fact that as a soft medic, I couldn't walk into my base's hospital and work at all? And the fact that when COVID popped off, most active duty medics were doing nasal swabs out front of the hospital and couldn't work inside of it because they weren't credentialed. So internally, we don't even give guys and girls the opportunity on the weekends to go see patients because they're not credentialed in the hospital on their own base, in their own branch of service.
It would seem that that would be the low-hanging fruit. I think that, like for me, I don't. I think that there's a limitation of working in the base hospital that's similar to the one just running sick call, is that, it's a much healthier patient population, so you're less likely on any given shift to see a lot of really sick folks. But it would certainly be the lowest hanging fruit, that there's no reason that our medics shouldn't be able to pick up shifts or half shifts or what have you at the military treatment facilities. And do that routinely. But I would love to see it where medics were, once a month were being given a day or a couple of days a month where their place of duty was riding with the local EMS service, flying with the local, critical care flight paramedic service, working at some of the local sort of more regional hospitals, like the smaller hospitals, and then maybe then every couple of years also doing like a what we more think of as an MPT at a larger academic center. And that way they get the breadth of experience in different kinds of environments that I think would serve them a little better downrange.
Definitely. And I think rural's a phenomenal model too, because they need help. Like you said, I remember you texted me, I can't remember how many months ago, where you were like, thank God I had my Emma tonight because I was the only one with any capnometry inside, or in capnography, excuse me, inside of this hospital. And it came really clutch. So that was having your background as 18 Delta and as an ER physician in a more robust setting, and then bringing that to someone that's resource struck. So you're not just bringing manpower. I mean, you're bringing brain power and then fancy toys.
I never bring any of my military equipment on shift under any circumstances.
It's not a military piece of equipment. You're a doctor. You buy things like Emma's because you're weird.
Well, yeah, that's true. I do that.
It just happens to be multicam.
And no, his is black, dude.
No, oh, it's sweet. Stealth.
All of my medical gear is tactical.
Cool. Hey guys, we're already pushing an hour, and as much as it seems like we have fixed the world's problems, this is probably going to continue for a little bit longer. But is there anything else that you guys think that we missed?
No, I think we covered a great bunch of topics, and I enjoyed the conversation. Thanks so much.
No, I appreciate you guys. No, I think we did pretty good. Just kind of summarizing. I don't even know what I want to say about summarizing. I think the key is just keeping everything in context. Okay, combat medicine definitely different than your basic civilian medicine. So getting some kind of education, some kind of bridge course. It's just going to be required. Okay, it's completely different patient types. It's different systems working in. Just getting used to working in a completely different environment is going to require some kind of education. And there's lots of resources out there, and people more than willing to help guys find that education. Cool. Well, hey guys, I really appreciate it.
Thank you for having me, Dennis. It was an honor to be on your podcast.
Thanks as always, Dennis. It was a pleasure to be here.
Thanks, Dennis. Thanks, everybody else. Appreciate you guys.
All right. Thank you. Have a good night. That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.